I'm going to spend a few minutes just to talk about the gaps in healthcare post-COVID. Post-COVID. And I'll really start by uh, saying COVID is over and we are clearly back to factory settings. No masks. I didn't see anybody washing their hands. No social distancing. So we're really back to factory settings. And in a way, it sort of speaks to how we think about healthcare. Healthcare is not only about are we aware, but I would like to argue it is about who bears the risk. And so the person who bears the risk, in a way, is the person who sets the tone. And so today I will talk about the work that we do by offering urgent care services through a network of freelance nurses to help us address what we would call the uninsured healthcare needs, of which, by every standard, mental health qualifies as one. If you think about the pandemic, right, in Kenya, it's estimated that 343,000 cases were confirmed, with only 5,688 deaths, right? And with that, because of the risk of the pandemic on the economy, the government had to take extreme measures. We're familiar with the lockdowns, the mask mandate, the requirements of to do hand washing, and eventually in late 2021, we were required to vaccinate our staff. That is the extent to which the government assessed the risk and took decisions. Now, mental health. 25% of people who come to outpatient services have a mental health condition. That is of people who show up in the clinic. 40% of people admitted in hospitals have a mental health condition. So if you kind of think about it from the perspective of the decisions and the ownership that happened during the pandemic, the question then becomes, who owns the risk of mental health? And I'd like to argue from this work that the decision lies in our hands. So, if you think about mental health as well as other conditions which are co-associated with mental health, these would be considered uninsurable risks. That means they are affecting too much of a population where it no longer makes sense for an insurance cover to take care of, including the National Health Insurance Fund. If 25% of people who walk into every clinic every day have a mental health condition, then let's set the expectation clearly. There is no way NHIF would cover for mental health, because that means every day 25% of the population is generating a bill, a claim. So the question becomes, as we think about it, what must we do? And when you think about mental health or the spectrum of conditions which we would characterize as uninsurable health needs, you have essential healthcare for the elderly. Every worker in our organizations is worried about the healthcare of their parent. That is a trigger for mental health. The occupational risks of farmers, they're exposed to pesticides, fertilizers, dust particles, either while in transit or in the market. They are exposed to particles from cow dung or chicken poop, right? Who takes care of that risk? Learning disabilities. If you talk to teachers, in every class, about 10 kids who they can't control. Back in the days, they were called stubborn. Now, they have learning disabilities. 10% of every child in a classroom has a condition that needs some medical attention. Can that be insured? Painful periods, for thinking about it from a gender-sensitive perspective. Girls in the classroom who don't have access to Panadol, who takes care of that need? So we really have to rethink about healthcare service delivery in the face of what would be pandemic or diseases or health needs of pandemic proportions, which the government has not, or governments have not established the urgency to think about a drastic action like a lockdown. So what do we do? Next slide, please. And so if you think about who bears the risk, at the national and the private health insurance level, they are willing to accept risks for, let's say, inpatient stay. And that's why you might have a psychiatric cover. Or acute conditions in the primary healthcare settings. And with Linda Mama, antenatal and maternal healthcare services. For conditions like HIV, AIDS, TB, malaria, that affect the population because of the risk of spread, you have now donor partners that come in and provide subsidized services for free. Next slide. So when you think about those uninsurable conditions that affect populations, which are the root cause of mental health? Next, please. Right? We start thinking of coughs and colds, runny tummy, tooth decay. These may sound like common things, but this is what starts creating mental health in the workplace. Anything that has the potential to make one feel internally displaced is a risk factor for mental health. Any situation that says, I may not belong, is a condition for mental health. Lifestyle disease support. We have pain, substance use, hypertension, vision issues. Many workers have undiagnosed visual conditions, and they are treated as poor performers. It threatens their livelihood. But what we are also seeing is that most people are worried about the health care of their parents. And so you have now an ecosystem, next slide please, whereby over 15% of the population that is insured, which we call the informal sector, are now having to own the diseases they carry. And so we have to think about a healthcare delivery system that seeks an alternative approach, because if we have to wait for these persons to get into the healthcare system, they wait for severe conditions and they are hospitalized. And that's why you have disproportionate amount of hospitalizations amongst informal workers in the healthcare system. So who are these informal employers? A lot of you in the room employ people. You have SMEs, you have NGO organizations, you have startups, but all of us are in our homes, we're employers. We employ house helps, we employ guards, we employ drivers, delivery guys, the boda guy whom we call to deliver stuff to us. Those are people who we indirectly employ. Farmers, school traders. So what do we do about them? Next slide, please. The economic burden of this population in terms of healthcare is twofold. They get the double whammy. On the one hand, they cannot take time away from work, because a cough and cold could mean 2 days away from work, which is 2 days of lost wages. We have estimated on average a market trader could lose $35 to $50, that is 3,500 to 5,000 shillings worth of sales a day if she stays home because of a cough and cold. Which technically, if you go by the pandemic guidelines, she should not be in the market with a cough and cold. They borrow money to pay for care. They are unsure which clinics to go to. The clinics where sometimes are not affordable, the good ones, and they are not sure even which labs and medications to buy. So it's a state of absolute uncertainty, and that is a trigger for mental health. When they go to the clinics, long wait times, the transport cost, the actual cost of healthcare, the poor quality of medicines, and the fact that their benefits under NHI for those who do have is limited, is a big risk factor for mental health. Next slide, please. And so, what we have tried to design to say, what can we do to support the small to medium-sized enterprise with a service plan that really helps early identification of risk factors that are associated with mental health or actual mental health, and support them so they can readily have access to a healthcare provider without the risk of losing wages when they're in a sickness episode. So we look and say, okay, the average wellness, if we retail the price, worth 7,500 shillings, they can be checked for common conditions which could affect their ability to do work. And we could help them identify mental health risks. They have access to a general practitioner. If you one slide, please. walking or by phone. So if you're feeling low, you can call a doctor. You do not have to leave your workplace. If you're feeling uncertain about the job certainty, you can call and speak to a doctor. That is something that your insurance cover will not allow you to do. And if you need essential tests, for example, last week we did for one company that has factory workers, we did over 1,000 employees and 48% had UTIs, of which 95 were women. Think about the level of distress amongst the workers. So access to essential tests. So total market value of 35,000 shillings with discount on medicines, and for those with chronic conditions, they're enrolled. And we can now use their NHIF cover while they are at work to offer them medication while they're at work. Now, this is the plan that we have designed for blue-collar workers. Next slide, please. And so our early data is showing that it helps companies reduce lost time away from work. If you ask a market trader, how many times have you, in the last 6 months, on a program, have you left your workplace to go to the clinic? It's none. They are very satisfied. Then it helps them better use their NHIF cover, and it helps reduce medical claims for a few clients who also have private insurance. So it's important for us to really think about how we're going to deliver healthcare in a situation whereby mental health requires an almost constant access to a medical provider. Next slide, please. And so really we are relying now on a network of nurses whom we want to be able to dispatch within 30 minutes to the workplace, to the market, to the to farms, to go meet fundis, so that they can access care without having to leave their workplace. Because the cost of leaving the workplace is more than the cost of healthcare. Next slide, please. So it really starts with just calling. They don't have access to internet, some of them. They don't have, they may have literacy barriers. So just call, don't fill out any form, just call, and the process starts. And it really makes it easy. So far, we have done over 70,000 patients, and the results are phenomenal. Satisfaction, convenience, and we have not had to pass a new mandate. And our hope is that we can work with channel partners. We've had some conversations with folks in the room to figure out how to make this service affordable or financeable, because it's a financing conversation. And back to the question is, who bears the risk when this person has a mental health condition? My answer, it is the employer to put in measures to make sure that the staff can call a doctor on demand without having to lose a shilling of wages or to lose their business. Thank you very much.
Thank you so much, Dr. Lantum. Such an important conversation to have right now, talking about access to mental health, the particular groups that are affected, and how can we better it. Now I'd like to invite Mathew Mutiso to share with us his presentation.
Good evening. My name is Mathew Mutiso, and I'm the Executive Director of the Coalition Action for Preventive Mental Health. Yes. You can go back to the other slide. Thank you. I think most of you have been given an F4 with some questions. As I go through the presentation, you'll find time to fill those questions. Just keep it to yourself. Tick or write yes or no, depending on how you can answer them. And then tally them at the end of it, and then I'll explain later. So what we do, next slide please. This is our organization. It's a coalition of mental health organizations in the country. We are about 140 CDOs at the moment, with different interventions at community level, mental health interventions. And we do strategic litigation, we do advocacy, capacity building, research, networking, and collaborations. We believe in investing at the grassroots. We can use our local resources to prevent mental health and promote mental health. Prevent mental health illnesses and promote mental health. Next one. This slide talks about what Doctor has also spoken of, lack of access and affordability, availability of mental health services. you'll find like fewer than 1% government-owned organizations, private-owned, provide mental health services. Yes, and at community level, at level 3, where most of the population is, there is no mental health services. In our country right now, for 15 out of 47 counties offer inpatient services, and according to statistics, 1 out of 4 persons has in his lifetime or at any time a mental health condition. So if you're assisted to 4 people, perhaps you could be the one, or the other person could be the one. So there is a high need for us to take care of our mental health. That's what the government funds, 0.01% of the budget, which goes to salaries and drugs, because we don't fund preventive or promotion aspects of mental health. In Kenya, we have about 62 psychiatrists and 600 psychologists in a population of about 45 million people. 12% of persons are diagnosed with depression, psychosis, and bipolar. That's the most prevalent. 20% outpatient people, like doctors mentioned, and 40% of people who go to hospitals, inpatient services, have mental health issues. We find that in low-income countries, which happen to be Kenya, in the low-income countries, our higher-income countries, they focus more on preventive aspects of mental health. The budget is at the preventive and promotion, while in the low-income countries, we focus on treatment. Okay? We put our money in treatment rather than prevention. And at community level, you find access is 1 out of 27. We have 160 rehab centers in Kenya, and only one in Kenya is community-based and free, and it's in Mombasa. So our intervention, we looked at the prison population and tried to understand the relationship between mental health and crime. And we discovered that when mental illness increases, criminality tends to increase. And in our prison right now, you'll find that the population in our prison is at 200%. I think that we have even now a campaign going on for 1 bed, one inmate. But at the moment, inmates we are actually overpopulated. And you remember during COVID, there was an increase on suicide cases. Many people died by suicide. The next slide. This is a study that was done by the CDC, Center for Disease Control, in the 80s in the US. And it talked about adverse childhood experiences, the form I've given you. And it says that adversities that happen to a person between the ages of 0 to 18 years increase an affinity towards crime, or at later stage, doctor has mentioned some of those things, it will increase other negative health outcomes as you grow. Because between the ages of 0 to 18, a person has a lower resilience. And these adversities happen sometimes within our household. They look like divorce, they look like homelessness, they look like parental mental illness, they look like alcoholism and drug abuse in the family, emotional and sexual abuse in the family, domestic violence, maternal depression, bullying, and so on, within the household. Within your environment, they look like climate crisis, wildfires in some areas, smokes and all that, natural disasters, earthquakes, and so on. Conversations on climate change and mental health. Within the community, they look like discrimination. When you're discriminated within those age, if you're below 18 years, they look like historical trauma, intergenerational, from one generation to another. They look like community violence, lack of social capital and mobility, racism in some other contexts, poor water and air quality, pollution again, lack of jobs, substandard wages, poverty, and so on. These adversities have an ability to reduce individuals, communities, entities' resilience. And what happens? The next slide, please. This is what happens if there are no interventions. I've talked about those. They are called S's, 3 realm of S's. Parental neglect, abandonment, such kind. What happens is that how they affect us when a child is growing in the early childhood. A kid tends to have a sort of poor emotional regulation. Sometimes we call them stubborn kids, or kids who cannot be held, or kids who are just chaotic. Their brain starts developing poorly. For example, if a kid is in a home state where there's an alcoholic father or mother, that kid always looks timid. Their brain, and because also there'll be a lot of lack of sleep, because there's always noise in the house, their brain start performing poorly. Within the formative years of maybe 3 to 10, they start having behavior problems. The kids start lacking empathy. They start having relationship problems, lack of trust for others, because maybe the kid has been sexually abused, they have been bullied, they have been beaten, and so on. At teenagehood, you'll start finding the person having poor self-image. You'll find them seeking attention, attachment problems, can't relate either with the opposite sex, they isolate themselves so much. They start becoming manipulative, or they are prone to be manipulated. They start using drugs and substance abuse. At this age, they start experimenting with cannabis, with muguka, with kakwota, all those kind of things. At that point is where you'll find also teenage pregnancies happening, because they're also experimenting sexually. As a young adult, addictions are so now into them. What it creates now is an affinity towards crime, because this person maybe at this point, they have dropped out of school for one reason or another, either because there's a parent who died, there's a conflict in the home, they've run out of home, so on and so forth. There's sexual behaviors that are funny, or maybe they are, with that word, I won't say, there's a level of imprisonment at this point. Either as a teenager or as a young adult. You'll find them in prison. And more often, those who get pregnant or enter in relationship, they end up having unplanned marriages. Because now it happened. It never becomes a choice. You're living by chance. And as you grow into adulthood, those diseases that doctor has spoken about, they start manifesting. Cancer, diabetes, hypertension, high blood pressure, arthritis, dementia, amnesia, stroke, and so on and so forth. In the meantime, you can be feeling that paper I've given you, and then you just keep your score to yourself. And the next slide. So our organization basically looked at a problem that is related to mental health promotion. We realized that to reduce childhood adversity, we need to do a lot of mental health promotion for people who are at risk, which we call universal prevention. Also promotion strategies for people who are at increased risk, we call selective prevention. Universal promotion and prevention could be for all of us. Those who are at increased risk, the children, mothers, and so on. Mental health also promotion, indicative promotion for people who have gone through lived experiences. Why? Because we need to reduce stigma. Structural stigma, systemic stigma, institutional stigmas. And these are barriers to employment. If you have a mental health issue, or you cannot say, I have bipolar. Few employers will take you in. Yeah? Education, when you go to school, isolation, or because your family or a person in school that you know has a mental health issue. Housing, access to treatment, even the justice system, how the media reports, and laws that criminalize mental health. There's also to reduce social stigma, the relationships that we have amongst ourselves, low social status for persons, we isolate them, we reject them because they've said they have stress. Even at work, if you say you have stress or you're going through postpartum depression, you might be told that you're not productive, which leads either to absenteeism, doctor has spoken about it, or presenteeism. You're just at the workplace, but you're not productive. internalized stigma, how people view themselves. Nobody wants to say, I have a mental health issue, because of how you perceive yourself, how you stereotypes will affect you, and so on and so forth. The next slide. So what are we doing? We realize that for change to happen, systemic change, we need first of all to prioritize politically. We need to work at legislations, interventions. We took part in the Mental Health Act, and we are also now taking part in the criminalization of mental health. We are litigating, we are in court over, for example, the Suicide Act, which criminalizes persons who attempt suicide. You know, that's a crime in Kenya. If you attempt suicide, you'll be jailed for 2 years instead of being taken for rehabilitation. If you have an addiction, maybe you are smoking, you've seen the addiction for us, we look at it from the point of pain. If you are caught with maybe marijuana, you'll be taken to prison rather than a rehabilitation center. So we are looking at laws that are criminalizing mental health. And then we're looking at addressing various intersections of mental health with the SDGs, either education, nutrition, and so on and so forth. Even integration of mental health into the universal healthcare. We are looking at justice reforms. We're engaging the justice sectors, the judges, the magistrates, to reduce what we call sanism. These are prejudices and stereotypes that come into the courts from society. I've talked about litigation. We are looking at having trauma-informed courts, alternative to incarceration. Rather than having people in prison, let's take them to communities and rehabilitate them, which we call restorative rather than retributive justice. We're also working towards mental health funding, globally and locally, funding through the Global Fund, intersections of mental health and HIV, mental health and TB, because they are related. We are looking at reducing child poverty and increasing children well-being. These are things that are ongoing, and we sit in different organizations that advocate for them. The next slide. And lastly, I think what we are doing is also offering community support, peer support networks. We are building them through the coalition members. We are empowering community centers, social justice centers. At the same time, what we do, we have programs in prison, because that became our soft spot for applying our intervention. So what we do in prison is we give them, we train them on entrepreneurship, but we also realize even if we gave them money, or whoever gave them money, if they don't have mental resilience, even the money, they won't use it, put it into good use. So we do entrepreneurship classes and also psychosocial support classes in some of the prisons. We also engage churches, the National Council of Churches, the Interreligious Council of Kenya. We've had several conversations with them. We are engaging universities. We've done a lot of work, webinars on maternal mental health, on various aspects of mental health. We also advocate for workplace change and wellness policies through the HR policies, integration. And we also advocate for building of coalitions like ours, so that people can advocate for better laws and policies in mental health in all the spaces. And lastly, what we do is also advocate for people to be trained on the Quality Rights Initiative. And this is done by the World Health Organization. And it's for free, and it's a model that anyone can learn and understand a better human rights approach towards mental health. Thank you so much.
Thank you, Mathew. As you are sharing the negative effects that come as a result of lack of mental health awareness and intervention, I was just going back to that, saying that now more than ever, prevention is really better than what? Than cure. Indeed. Now I'd like to welcome Wahinya to share with us her presentation.
Good evening, everyone. You'll bear with me, I have a cold. Community mental health volunteers. Next slide, please. So we use a methodology which we call the trauma-informed community empowerment model. And we have a fellowship program. That is how we train our community mental health volunteers. It's a 4-month program where we do 15 days of classroom experience, and then we couple that with the field work, where they have to do group therapy sessions, 10 of them. We also do continuous mentorship and taking care of their well-being. And finally, we do certification of the community mental health providers. We certify them together with county governments. But at least we do involve the Department of Health to also monitor and also do some form of mentorship. Next slide, please. So we do contextualize the trauma-informed community empowerment framework and model that we use to each environment, context, and culture. Our lessons have been that when we talk about mental health, for example, in a Kenyan context, in an African context, it's very, very different from the Western world. And so we have had to contextualize this, the language. Yeah, when you talk about, for example, terms like, bipolar disorders, these kind of terms are very, very difficult. No one can relate with them here. And also just demystifying it. What are the needs within each context? Like we have seen in South Sudan, it's post-traumatic stress. In Kenya, the issue basically is more of depression. So these are some of our materials that we use. They are very basic, that even someone who is illiterate can actually use them. Next slide, please. So currently we've trained over 600 caregivers in the Global South, in South Sudan, in Mozambique, we're in Ethiopia, Somalia, and Kenya. Recently, we have just trained 50 community mental health volunteers in northern Mozambique, where the war is going on. And they are delivering basic mental health services through group therapy sessions in the internally displaced camps, people's camps. Next slide, please. So we have been able to reach around 6,500 participants through this network of community mental health volunteers. Our sessions are done in the community. They are very basic. Our materials, they are very user-friendly. So wherever you are, our community mental health volunteers are actually able to deliver these sessions at the community level. Next slide. So I'll just share with you a bit of our results, what we have been seeing. And this is in a project that we just implemented in coastal Kenya on intimate partner violence. So one of the things about the trauma-informed community empowerment model is that it can be integrated in peace building, in livelihood programs, in health programs, education programs. And this was for an intimate partner violence program in the coast. And what we were seeing among the participants is we did see 64% decrease in post-traumatic stress disorder. And here we were using international standard measures. One of them is the ACEs that was just shared by Mr. Mutiso. That's one of the standard measures, Harvard Trauma Questionnaire, Patient Health Questionnaires. And then in depression, we were seeing a 55% overall decrease. And the gold standard is usually 5%. So, when we see 55% overall decrease in depression, then we know that we are doing the right thing in training our community mental health volunteers. In aggression, we were actually seeing around 62% reduction in physical aggression. And then we were seeing 90% becoming less aggressive towards their spouse or partner. And 69% who are starting to say that reporting perception of intimate relationships as healthy. And also we were seeing 26% decrease in emotional dysregulation, meaning that, emotional dysregulation, as Mr. Mutiso was saying, is linked to aggression, violence, and many other factors that affect our mental well-being. So in terms of systems change, One is that we are actually challenging traditional beliefs and attitudes and addressing issues of stigma. One, that it is only a psychologist or someone very high level who can deliver mental health services. We do have community mental health volunteers who are actually delivering basic mental health services. And this has actually made it possible to access these services in very hard to reach communities and to make them more affordable. So, it also has resulted in saving of costs, both for the client, right, and for the entire mental health system. Because like you saw the data that Mutiso was sharing, that we have very few psychiatrists, very few psychologists, and these services are very, very expensive and in most cases inaccessible. So one of the things, as I finish, next slide, we also have one more physiological measure. We call it the heart rate variability. And we were seeing a 15% decrease in critical heart stress. And today, I'm glad to say I'm here with my colleague Dennis. And if you do want to have your heart rate variability checked, we'll be setting up and we can do just 3 minutes if you're interested. But basically what we do is that we use a device which we are able to check levels of critical heart stress in terms of the amount of stress your body is carrying and how well your body is able to deal and manage that stress. So that is something we should be able to do for a few people after this. Finally, this is one of our tools, a sample tool, for example, that we use. We call it the sticks and bricks. And basically, it's a check-in tool. We check in on our own well-being. And the sticks, they represent the amount of stress that you're carrying. And so basically, when I'm doing a check-in, I'll be saying, for example, today, right now when I'm here, at 3, that's me. On another day, I'd probably be at a 1. And I'm able to explain why. Why do I feel I'm like at a 2.5 heading to 3? One, it's the pressure of doing this presentation. I have a cold, so, and then there's a report waiting for me, so that, again, So we use these kind of tools that are very simple to help us check in with ourselves. So this is just one of them. And these community mental health volunteers, they don't need manuals and a lot of technical jargon to be able to deliver this kind of services. So I'm going to stop there. Thank you.
Thank you so much, Anne. I think one of the recurring messages for me is the power of our local communities and how we have to tap into them as a resource to really look at the mental health pandemic that's affecting our countries, our continent today. So now I would like to have a more in-depth discussion, and we'll have panelists join us on stage for that. So as I call your name, please join us up here. For the panelists, we have Dr. Eleleta Abay, the lead research and coordination at Bela Risu Foundation. We also have Dr. Wilfred Njagi, the co-founder and CEO of Villgro Africa. Kindly join us on stage. All right. In addition, we have Clive Angwenyi, training manager at ICA Lion Academy. Thank you. Welcome. And then another panelist, Naom Monari. She's a nurse, manager at, social innovator and founder at Bena Care. And now to lead us in that conversation, I'd like to invite our moderator, Dr. Beatrice Kairuki. And she works, at public health and data, with public health and data analytics, and she's a consultant. Welcome, Dr. Beatrice. Yes, you can sit.
Is Dr. Leah from Madison here? Please come up. Sorry. Let me introduce her. Thank you. Dr. Leah from Madison is also a member of the panel. She's currently the Medical Services Manager at Madison General Insurance. She's a trained medical doctor who's digging a bit deeper into insurance. Thank you. So, welcome, panelists. Thank you so much for the discussion that we've just had. I think because we're talking about the ecosystem for mental health, allow me to, one, introduce myself, two, give a definition for mental health and well-being, and then three, just walk you through how our panel discussion is going to be, so that you're able to follow on. I'm a very big proponent of locating my audience and the crowd before we start on the journey. So allow me to locate you and locate us. So I am Dr. Beatrice Karaoke. I'm a medical doctor and a public health specialist. I am in non-clinical practice, and my area of focus is public health, analytics, and digital health. So I'm hoping that eventually this discussion we shall end up about digitizing mental health services somewhere. Now, definition was the second thing, right? So a definition for mental health. First, let me ask, if you're healthy, mentally healthy, stand up. No, I didn't say if you're unhealthy. I said if you're healthy, stand up. Oh my gosh. And the panel, if you're healthy, stand up. Like everybody in the room who thinks they're mentally healthy, stand up. Be bold, be brave. I know Mathew has given you a questionnaire to fill. Ignore the questionnaire for now. Just stand. Well done. All right, have a seat. So mental health is a state of mental well-being that enables people like you and me to cope with the stresses of life, realize our abilities, learn well, and work well, and contribute to our community. WHO definition. Okay? So, we're able to cope with the stresses of life, realize our abilities or potential, learn well, and work well. If you're mentally healthy, please stand up. Again, with that definition. Well done. Please note Dr. Moka is seated and, and Wilfred. All right, thank you. Have a seat. Thank you so much for that. Okay, so for this session, how we structured the session is to look at different players within the mental health space or within the health space and begin to talk about the particular needs that they meet, as Mathew Mutiso from the Coalition of Preventive Health put it. So the way our session is structured, sorry, if I was a teacher, I would be moving people around so that we have a flow, but it's okay. So we have three groups of people with us on stage. We have people who deal directly with patients. Their organizations deal directly with patients. So we'll talk a bit about patients. Then we have groups of people or organizations represented where people deal with the providers. So they work with the healthcare organizations. So we'll call those the providers. And then the third group is those who deal, who are in the health space as payers or financiers, people who provide payment solutions. So those are the three groups of people that we have represented here. Focused greatly on three key things within the ecosystem. First is availability and affordability. as put forward by Mathew and by Dr. Anne. And then Dr. Moka talked about risk and financiability of commercial solutions for this mental health space. So amongst our providers, you will see those providers who are dealing directly with patients and providers who are dealing with other the health professionals. You will see people speaking in the space of social enterprise.
One of the recurring messages for me is the power of our local communities and how we have to tap into them as a resource to really look at the mental health pandemic that's affecting our countries, our continent today. So now I would like to have a more in-depth discussion, and we'll have panelists join us on stage for that. So as I call your name, please join us up here. For the panelists, we have Dr. Eleleta Abay, the lead research and coordination at Bela Risu Foundation. We also have Dr. Wilfred Njagi, the co-founder and CEO of Villgro Africa. Kindly join us on stage. All right. In addition, we have Clive Angwenyi, training manager at ICA Lion Academy. Thank you. Welcome. And then another panelist, Naom Monari. She's a nurse, social innovator and founder at Bena Care. And now to lead us in that conversation, I'd like to invite our moderator, Dr. Beatrice Kairuki. And she works, at public health and data, with public health and data analytics, and she's a consultant. Welcome, Dr. Beatrice. Yes, you can sit. You can sit.
Is Dr. Leah from Madison here? Please come up. Sorry. Let me introduce her. Thank you. Dr. Leah from Madison is also a member of the panel. She's currently the medical services manager at Madison General Insurance. She's a trained medical doctor who's digging a bit deeper into insurance. Thank you. So, welcome, panelists. Thank you so much for the discussion that we've just had. I think because we're talking about the ecosystem for mental health, allow me to, 1, introduce myself, 2, give a definition for mental health and well-being, and then 3, just walk you through how our panel discussion is going to be, so that you're able to follow on. I'm a very big proponent of locating my audience and the crowd before we start on the journey. So allow me to locate you and locate us. So I am Dr. Beatrice Kariuki. I'm a medical doctor and a public health specialist. I am in non-clinical practice, and my area of focus is public health, analytics, and digital health. So I'm hoping that eventually this discussion we shall end up about digitizing mental health services somewhere. Now, definition was the second thing, right? So a definition for mental health. First, let me ask, if you're healthy, mentally healthy, stand up. No, I didn't say if you're unhealthy. I said if you're healthy, stand up. Oh my gosh. And the panel, if you're healthy, stand up. Like everybody in the room who thinks they're mentally healthy, stand up. Be bold, be brave. I know Mathew has given you a questionnaire to fill. Ignore the questionnaire for now. Just stand. Well done. All right, have a seat. So mental health is a state of mental well-being that enables people like you and me to cope with the stresses of life, realize our abilities, learn well and work well, and contribute to our community. WHO definition. Okay? So, we're able to cope with the stresses of life, realize our abilities or potential, learn well, and work well. If you're mentally healthy, please stand up. Again, with that definition. Well done. Please note Dr. Moka is seated and, and Wilfred. All right, thank you. Have a seat. Thank you so much for that. Okay, so for this session, how we structured the session is to look at different players within the mental health space or within the health space and begin to talk about the particular needs that they meet, as Mathew Mutiso from the Coalition of Preventive Health put it. So the way our session is structured, sorry, if I was a teacher, I would be moving people around so that we have a flow, but it's okay. So we have three groups of people with us on stage. We have people who deal directly with patients. Their organizations deal directly with patients. So we'll talk a bit about patients. Then we have groups of people or organizations represented where people deal with the providers. So they work with the healthcare organizations. So we'll call those the providers. And then the third group is those who deal, who are in the health space as payers or financiers, people who provide payment solutions. So those are the three groups of people that we have represented here. Focused greatly on three key things within the ecosystem. First is availability and affordability, as put forward by Mathew and by Dr. Anne. And then Dr. Moka talked about risk and financiability of commercial solutions for this mental health space. We'll be speaking to us about the providers, people who look after people who are in a space where they've lost their independence and the mental health of those people. The second provider, now speaking about it from an organizational perspective, is Wilfred Njagi. Wilfred is from Villgro, and they invest in startups. So he will take us through the journey of an entrepreneur, all right? And then the last two groups are pairs, but they're also the people who are in the general preventive space that Mathew talked about. So you, I, everybody else who's not at a higher risk than anyone else in the population. We have Clive from ICEA, Lion. He will talk to us about some of the protection, how financial protection can prevent you from stress. And we have Dr. Leah Wahinya from Madison. She will also take us through some of the initiatives in that space. We're together? Okay, so let's start with our providers. And I'll start with you, Dr. Eleleta. Okay, I think there's just one mic. I'll just pass it on. And Dr. Eleleta, could you just tell us a little bit more about Bela Risu and your experiences with meeting mental health needs for children and families who've already been exposed to some of the risk factors at that early age?
Thank you so much. It's audible? Okay. So my name's Eleleta. I'm a medical doctor by profession, also a public health practitioner. Today I'll be representing Bela Risu.
I'm actually representing Bela Risu because both co-founders weren't able to attend this event. They're currently conducting a surgical outreach in Angola, which is scheduled to take place for about a week. So going into the details about Bela Risu, we'll also be talking about our surgical programs as well. So the term Bela Risu means beautiful smiles. Our programs are centered around providing free surgical care to children born with cleft lip and palate. As Dr. Beatrice mentioned, we also do reconstructive surgeries for other deformities as well, particularly around craniofacial abnormalities. So cleft, to give you a bit of a background about cleft, it's an opening in the lip, the gum, or the palate that happens during early pregnancy, which causes children to be born with that particular defect. And aside from the obvious facial defect, these children also have several other medical complications. Like I mentioned, because of the gap, they're not able to feed well, so most of them end up having nutritional complications. Because of the gap, they're not able to articulate and enunciate their words very well, so they end up having speech problems. They also have dental problems. Because of the gap, their teeth are not able to form normally. And then now, in line with the theme of this discussion, it also predisposes them to having psychosocial issues as well. Because being an obvious facial defect, it causes them to be isolated and stigmatized and ostracized by the community, and even by their own families at times. So to speak a bit about our work with psychosocial condition, the thing about cleft is, one, dealing with this condition as a sub-Saharan nation, we know that mental health isn't really given a priority. Out of all the disease burdens that we have to deal with in children, we have malnutrition, pneumonia on one hand, and then we have childhood cancers and neurological conditions, so many things that we have to deal with, which makes mental health more of like a luxury. And then on top of that, cleft itself as a defect is not really given much priority as well. So dealing with it from a mental health perspective could be a bit challenging. And then also coming at it from communities that give religious and superstitious explanations to mental health symptoms, it's also quite challenging to be dealing with psychosocial aspects of cleft as well. And then most of our patients being children, you know, with adults, you can use so many approaches to deal with mental health issues, but when it comes to children, now you're forced to become innovative with your approach. So one of the methods that we've been able to employ quite successfully in Ethiopia, we're also trying to upscale these programs in other regions where we work as well, is an art-based therapy, where we bring children with cleft, both before repair and after repair, and mingle them with children who don't have cleft. And then we put them in this creative space where they're able to get in touch with their creative senses. It could be performance arts, it could be theatrical arts, it could be circus, it could be music, anything of that sort. So when we put them in that space, now the focus becomes the performance, now the focus becomes the art, it's no longer the cleft. And so these children are now able to be in a space where they don't focus on their cleft, but they're able to focus on their creative space. And by extension, now the community, when they see them performing these things, they're able to understand that these children are not defined by their deformity, but rather defined by who they can be. So this program allows these children to be empowered to find their abilities and allow themselves to be reimagined by the community beyond their defect. So in the interest of everyone's time, I'll wrap it up there. Thank you.
Okay, thank you. Mr. Mathew, please join us on stage. Yes, Mathew Mutiso. So our next provider who will speak briefly, because she had a presentation, is Anne Wahinya. And Anne Wahinya presented the Global Trauma Project. Again, just take us through what your organization, how has it innovated in that space, and what are some of the gaps that are there in terms of being your model being financeable?
Yeah, thank you. So as I had shared, because Global Trauma Project, we are dealing more with the service providers. We are more interested with caregivers. And I know sometimes everyone asks, why do you say the word caregivers? It's because, as GTP, we are actually interested in everyone in this room, everyone who is out there providing services, reaching other people, leaders in their own fields, because then the kind of mental well-being we are talking about is for everyone, but there is so much stigma around the fact that when we think mental health, we think on the extreme end, you know, and it's either someone who is crazy, mad, I don't know, we call them all kinds of names, but we are just generally interested in general mental well-being. And in targeting local service providers, the biggest gap is actually funding for basic mental health services, because like my colleague has said, the challenge is that no one is willing really to fund mental health startups, for example, or something that doesn't have evidence-based. So first of all, the model has to get to a place where it's evidence-based, which we have. But on the other hand, the only way you can fund, and what we have seen works, is integrating mental health services into other services, into other programs. This is what works. This is what funders are willing to fund. You integrate mental health into HIV, you might get some funding. You integrate it into livelihood programs, workplace programs, but when it is standalone as a service, we haven't found people who are willing to invest in that. And so mostly we have been in providing these kind of services. For example, in war-torn countries, it's been integrated in violence extremism programs, but on standalone is where we have the hugest gap for mental health funding. So we need more evidence, probably, to show, you know, we don't need to keep integrating for it to get funding. So this is the hugest gap. And of course, getting a proof of concept. Everyone will ask you, where's the proof of concept that this works? But also, mostly like for us, what has worked is that it has been integrated into other existing programs.
Okay, thank you. And also highlighting the providers, the caregivers. So it's a great segue into the area of caregivers. We have Naom from Bena Care, who deal with home-based care services. And now maybe you can just briefly tell us about your organization and the role of caregivers or health professionals in that space where they're looking after people who've lost their independence, whose mental health may be at risk, or mental well-being may be at risk.
Thank you. So as she said, my name is Naom, and I'm the founder of Bena Care, which is a social enterprise that is based in Nairobi, Kenya. And what we do is we tackle the economic and emotional costs of long-term hospital stays for patients and their families. And how we do this is by building a large network of healthcare workers where we connect them to patients that are in need of care nearest to them. And we mainly also focus in rural Kenya, where when one family member is in need of long-term care, another family member is often available to step into the caregiving shoes and provide untrained care. So on this type of care, we provide training on the basics of caregiving to these caregivers, where upon training, they are able to step confidently into their shoes and provide supportive care for the patients, while Bena Care only comes in for clinical care and service monitoring. So since 2017, we've been able to work with more than 9,000 healthcare workers, and more than 30,000 families have been impacted by what we do, because we've saved them more than 50 million in healthcare costs. I'm so honored to be here with one of our funders and supporters, Villgro Africa, that have funded us over the past few years, and we have also received support from IDRC and Making More Health, which is also here, as well as Ashoka and Global Citizen. Now, if I'm to briefly speak about the role of these healthcare workers in this space, in the mental health awareness space. Number one, I'm speaking from the perspective of an employer of thousands of nurses and a nurse as well. And I'll speak about nurses. We do employ other healthcare professionals like physiotherapists, but because more than 80% of our employees are nurses, I'll speak about nurses. And on these, I kind of think they're the most vulnerable groups when it comes to mental health in the workplace. And this is because of the daily stresses that they encounter as they go to work, starting from they face death every day, where they have to watch people die, or they have to watch things happen helplessly when they cannot actually help it. Another thing they face is very long work hours. So the standard 12-hour shift is very long for the healthcare workers, and I think this has very bad negative energy on them. And we can also look at low pay, which is almost everywhere in the world for the healthcare workers. And most importantly, the caregiver compassion that they have, what do I call it? Compassion fatigue. So they have a lot of compassion fatigue and unsociable hours where they are working maybe nights, and during the day is when they are available to talk to people who are working during the day. So this is contributing to a lot of stress for them, and they are considered to have mental, I don't want to call them issues, as somebody said. So they are considered to be in a space where mental wellness is a concern for them.
They are at risk, actually.
At risk. Thank you.
Yes, they are at risk. They are at increased risk than most people in the general population, right? Okay, so we've heard about caregivers, lay caregivers with the trauma project. We've heard about professional caregivers with Bena Care. Let us hear a little bit about actually what Wilfred provides for entrepreneurs like like Naom in the journey of the entrepreneur to provide healthcare or be in the health business. Wilfred from Villgro, go ahead.
Thank you. As I answer that question, I also want to invite you to ask yourself what you're going to do about improving mental health of those you live with in your home. We saw the assessment that we did from Mathew. It shows clearly that mental health starts where? At the household, right? So as I answer what I'm doing for startups, I also want you to answer for yourself, what are you doing about mental health of those you live with, your siblings, your parents, so that we can make it better. It's one area we can't ignore. So at Villgro, I wish we could have done more than what we're doing, but one of the things we've been looking at is these are occupational health and safety checklists that we tried to implement with some of we did a pilot with about 4 or 5 startups. This was a comprehensive checklist built by Gideon's Foundation, one of our funders, and it was looking at the occupational health you provide for those that work for you. And we did it for our startups, where we asked, and this was just after COVID, are you providing the PPEs for your healthcare workers, for example, if you are Bena Care? Are you taking care of other occupational health hazards and issues that then become trigger points for mental health, right? We saw during COVID a lot of mental health issues experienced by nurses and caregivers, yeah, because it was taking a toll on them, working under pressure, seeing people die, and these stressor levels, as we saw in the, I like the check-in of the lady carrying firewood up to a point. So at what point does it break, right? And you don't have to wait until it breaks. So what we did with that assessment is, first of all, make sure that healthcare workers that work for our startups are taken care of. And by doing that, then we are sure that they will offer better care to the patients. The other thing we've been trying to look at is we are currently looking for a consultant or a provider that can also look at now the founders themselves. You saw when we were asked, you're the one who asked how we are doing mentally, and you saw Moka remained seated. Just because the life of an entrepreneur, there are so many things you're thinking about as an entrepreneur, including whether you'll make payroll or not, yeah, whether you're going to be able to raise that round of funding. It's a real issue that affects how startup founders show up and how they run their companies. It's something we're looking at Villgro internally. So if you know any providers that can help us with that solution, please send them our way. Thank you. And answer the question with your neighbor. What are you going to do about mental health of those you stay with? Thank you.
Okay, you know, I used to laugh at people who always do this and saying check one, check two. Today I find myself in that position. Yeah. So please don't laugh at me. So I hope we're beginning to see across the spectrum of healthcare what mental health issues are there, what kind of solutions are there. Given that this is a university institution that really focuses on entrepreneurship in the social space, one of the questions I want us to keep in mind, even as we listen to the next group of people, is Dr. Moka's question. Who takes the risk and how do you make it financeable? So far, we've heard about integration, integrate it into HIV, integrate it into violence and war-torn area programs, integrate it into restorative interventions for cleft. So how do you make it financeable as a standalone in whatever, and that's a question to all of you to keep in mind even as we continue the discussion. So the next two people represent organizations that classically would be categorized as pairs. We'll start with ICEA.
We do run financial clinics across different institutions, different organizations and companies just like yours. It's free of charge. Reach out to us. After the mass financial clinics, we do have fit for purpose, well-trained, adequately capacitated financial advisors, 2,000 of them spread across the country. They're able to handhold individuals in the different institutions, different companies, different social enterprises, and guide them towards protecting and planning how they will use their money. So they're wealth management experts. In addition to that, we have various areas where we have come up with innovations. So the first area is around product innovation. We have an interesting solution called medical second opinion. There are instances where you do visit institutions and you're given either a terminal diagnosis and you'd want to get a second opinion before you commence on a treatment regime. We do have that facility as a standalone and also embedded in some of our solutions where you can say, hey, before I start the treatment regime, whether it's for mental health treatment, let me reach out and extract value from this medical second opinion, and you're able to get a panel of doctors and experts who will look at the diagnosis and come up with a more efficient treatment regime. They can also propose to change your regime so that ultimately you're able to get better efficacy, better treatment. We also do have service innovation. I've mentioned that indeed I've come with well-trained financial advisors. Please find time to speak to them in the booth out there. We usually say, if you are in this room and there is someone who depends on your income to survive, then the responsible thing to do today and tomorrow is to speak to a financial advisor. The third one is technology innovation. We do have digital systems that enable you to access our services wherever you are. So we are able to reach out to as many people as possible in a non-discriminatory way. Our service cuts across. Then the fourth thing is marketing innovation. So over the years, insurance has been one of those, insurance and financial services solutions have been one of those things that need to be debunked, demystified. More often than not, I sit in panels and people say that financial advisors, financial experts use very, very technical languages. So we are simplifying that process. As a matter of fact, we want to come to your nearest village, nearest ward, and speak about insurance and finance in your local dialect. So that's the area we are doing marketing innovation around. And last but not least, Daktari, we are big on working with communities, big on working with social enterprises. So we do have corporate social innovation through our financial clinics. Please, if you are interested, go to a booth, register. It's for free. We will come speak to your people about money in a very practical way. We are very passionate about personal finance management. And as I started by saying that financial distress, poor personal finance management is directly linked to poor mental health.
Okay, if you are still healthy, the financial piece standard. You don't tell me no one is helping the financial piece. Okay, so there's a book out there, and Clive also does volunteer on Family TV as for financial clinics. So if you're not able to catch that information there, there's also the Family TV piece. There is also information through the Family TV piece. I want to pose a question to Clive and ask him to hold on to it until we come back to him again. And that question is, for the second opinion, who bears the risk and who pays for it? Okay, so our last representative today is from another of the traditionally classified as pairs. She's Dr. Leah Wahinya, and Dr. Leah is with the Madison Group. Maybe you can quickly just walk us through what your organization is doing, targeting mental health, psychosocial support for mental well-being, and psychosocial support for our general public. That's everybody in this room.
Thank you, Dr. Beatrice. So Madison Group, we actually a group of companies where we have the gender insurance company that also has the healthcare, which I'm part of, going by the fact that I'm a medical doctor. We also have the life company, and we also have an investment company. So looking at mental health, and it's good, Clive has mentioned that financial risk and financial exposure actually exposes us to a lot of risk towards mental health. And so if you're protected financially, somehow it reduces your risk. And even you look at the people that are dealing with trauma cases at home, the pamphlet that you were given previously, when I looked at those questions, you can see a lot of issues around home, and you can see a strong connection with financial challenges. So at Madison, we look at it from two different areas, from the preventive side and to the curative side. So starting with the curative side, the health insurance company actually provides for mental health care, not as a standalone product, but inclusive of the other services from outpatient, inpatient. Dr. Moka mentioned about the care. It's good to mention that for us, we provide both preventive from a perspective of wellness. We do offer general wellness checkup that includes mental health checkups in partnership with our service providers. And Dr. Moka is actually one of our partners, and happy to be in the same panel. So we offer that, and we extend this to all our clients. This includes the direct clients, we call them the retail, we have the SMEs, and we also have the corporate accounts, where maybe an institution like this will fall under the group account. So we will offer solutions, of course we'll tailor make them, and this will offer both preventive and curative. When we come to the largely solutions that will actually cater for everybody here, we look at it from the gender side. Anytime that, let's say, you're driving on the roads and you're on a third-party cover, because that is the bare minimum that you require by the Kenyan law, you are always worried, what happens if I have an accident? Yes, the other person is covered, but what about myself? So for us, we're able to offer comprehensive products that will actually cover, including your mandamano, just at an extra premium. Because you can imagine, like in the recent past, we've been having a lot of mandamano. Some of us have had to go to work and drive, and you always imagine, what if you get caught up in all that hullabaloo? What happens? If you're insured with Madison under the comprehensive package, then you're sure you're comfortable, because whatever happens, at least you're taken care of. Generally, I will say, from the life perspective, we have products across the whole life cycle, meaning that from the minute you're born, you have a child, you can actually have a life policy with them. We actually have a very good product called Bima Karo that ensures that as you take care of your child, then you know the education is taken care of. And the beauty of this is the fact that it takes care of the child when you're still alive, and in case something happens to you, like you have permanent disability, or you actually even die, you have waiver of your premiums, and your child is taken care of. When you have that as a parent, I think you have peace of mind, and you don't have to worry. Like now, parents just took back their children to school. You can imagine the many fights in the homes that, hey, we don't have school fees, what's happening? And that has contributed a lot even to family breakouts. You know, like even in the West, I think the number one cause of divorce is actually financial problems. So from the education policies, then you have investment policies, where basically you can use it as a savings. And this being a university, you think about the people who actually qualifying and joining the jobs. We have products that actually allow you to save, and they are pretty flexible to whatever amount that you're able to. And good to inform you that we have a booth actually outside for Madison Group, and we have a number of our financial advisors who will actually be able to take you through what are the different products depending on your level of your career, etc. The other thing, of course, pension plan. My goodness, every day, there's always this conversation about NSSF, how much they're deducting the 200, and you wonder if the kind of lifestyle you're living right now, if you're going to rely on that 200 bob that is deducted from you, can you really sustain it? We know that people, once they retire, there's actually a high death rate when people retire. Reason because there's a change of lifestyle. You're not able to sustain. Maybe you used to have a club membership. Right now you can't attend it because the amount you saved was too little. So we have products for individuals, like you can open your own individual pension account so that you're able to save for yourself and just basically supplement on top of what even your employer actually contributes for you. Then of course, you get born eventually, unfortunately we die. We have last expense product that ensures that by the end of the day, even if you're not there, your loved ones, at least they don't have to bear the whole financial burden alone. You actually taken care of them. And maybe something I'd also would like to mention, especially if you have students around here and young professionals, is that you also offer professional indemnity, whereby as a professional, whether you're a doctor, whether you're a lawyer, right now we've moved to a very litigative culture where everything small, you actually get sued. So you need peace of mind that when you're taking care of your patient or you're offering any legal advice, that you're actually protected in case you're being accused of malpractice. So we offer professional indemnity that actually gives you that peace of mind. You can imagine if you're a doctor or even if you're a nurse, you're giving some services to a client, something goes wrong, what happens? We take care of all that risk. We provide you with a good legal profession who is actually able to handle your case. So when you look around all the products that we offer, they're actually geared to ensure that your mental health well-being is actually good. And I like the question Dr. Beatrice asked, that after Clive presented, how many people are mentally well? And I think, did anyone stand? I don't think so, including myself. Thank you, Dr.
Okay, thank you so much. So I think in the interest of time, because I see our attrition rate is pretty high, I'm going to just ask each of the panelists and our earlier presenters to speak to one thing that they feel or would like people to take home, given this is an entrepreneurial space, and this is a space where solutions to these needs by patients, by providers, and by payers all exist, and for us too as a general public. So I'll start on that side. By the way, before I do that, you've seen also divorce and mental well-being. How many are still healthy? Not your own divorce, exposure to divorce. That's what Mathew's questionnaires have, yeah? So there's so many stresses. You can see there's the finance, there's your social well-being, there's your home. Really, it's an area which everybody is affected. It's just that your level of risk is different, and the products, the solutions available to you depend on your level of risk. And that's why Dr. Moka's question, who takes the risk and how do you package it? Everybody here has presented a way they've packaged it, a solution depending on your level of risk, but how do you make it financeable? How do you make it move from the social space where it's funding, where it's grants, to a place where it can stand on its own? So we start with Mathew and Mathew, and then we'll go one each this way, and then we finish. Just your one thing that you want to challenge an entrepreneurial community in terms of moving us forward.
Thank you. I think I'll say one. I think first of all we need to change our laws, especially with the insurance companies. For example, if indeed money contributes to poor mental health and somebody dies out of suicide and you don't pay the beneficiaries, then because it's a criminal offense, we need to look into such issues and decriminalize suicide so that insurance company can pay beneficiaries. Yeah, that's one. Number two, for entrepreneurs, 1 out of 4 persons is a candidate of a mental health condition, and it could be you. And what it does, if you don't promote mental health in your workplace, it will increase absenteeism and presenteeism. And all this will affect your bottom line. Yeah, so you'll be spending a lot of money in healthcare. So prevent before you treat. Thank you.
Perfect. So the laws. What is criminal in terms of mental health and what is not criminal, because then that allows for solutions. Anne?
Thank you. For me, as caregivers, I do want to talk about self-care. We're very big on self-care. Caregivers take care of everyone else, and you think you're taking care of yourself. No. Taking care of other people and feeling good. I've paid school fees. I'm taking care of everyone around me. That doesn't mean you're taking care of yourself. The same way you take care of your physical health. Like now, when I had a cold, I took medication. We really need to think about our mental well-being and think about yourself. It's very, very difficult when it comes to mental well-being for someone else to care for you. So you have to find ways to do self-care. To entrepreneurs, one of the things is proof of concept. Very, very hard sometimes to get. We must use evidence. You must use data. Sometimes you don't need to reinvent the wheel. We already know what works. We already know what are the gaps. But you need to gather the evidence. And you need to check what the context, like we're talking about contextualizing, adapting. You may see something that is working out there in another country, but you need to contextualize it, adapt it, and use evidence and data. Thank you.
Okay, Dr. Moka. Remember Dr. Moka, checkups, yeah? Please go ahead.
Thank you very much, Dr. Beatrice. This has been an excellent panel. Thank you. Really, reflecting on the comments that have been made, I'd like to first of all say the tool that Anne shared was really helpful, and maybe Dr. Leah, we can use that to assess people during every wellness, right? Just choose your number, and that would tell us a lot, more than any questionnaire that we have people fill out. So I would say the take-home for me is make mental health visible, right? We have an environment where people are hurting and people are hiding. And when it blows up, it stings. So really, our role as leaders is to make mental health visible. And the tool that Anne showed, really, I think is the first step to make it visible. Thank you.
Perfect. Thank you, Dr. Moka. How many men here are carrying 4 bricks? Stand up. Entrepreneurs, yes, 4 bricks. By the way, it's a safe space. Stand up if you are carrying 4 bricks. Thank you. You know what? We sympathize with you. Madison and ICA Lion have a product for you tomorrow, right? Okay, how many women? Well, it's not firewood, but are about 3 to 4. I'm also checking who was listening to Anne. You remember, it's 1 to 4. On a scale of 1 to 4, by the time you're at 3, you're bending, right? So again, ask yourself as you go along. All right. Let's have Dr. Leah, and then we'll have Dr. Eleleta.
Okay, my takeaway is, well, being a doctor, prevention is better than cure. So all of us, we need to take care of ourselves, save while we can, ensure you have some form of health insurance, because, you know, without your health, you're not going to be able to do anything. When you're without a healthy employee, even for the entrepreneurs who are here, who have maybe 2 or 3 employees, ensure that they're actually well taken care of, because the minute they fall sick, and especially all of us that do have households in the house, you truly know you're going to take care of that bill. So, and at Madison, luckily we have a product for everyone. So let's take care of ourselves. And for the men, I think the men have a big challenge in talking to someone. Actually, for us, we also offer a toll-free line in partnership with our providers, where basically you can talk to somebody, because mental well-being, you don't have to wait until you actually break into depression, clinical depression. It's that simple. You start being withdrawn, you're not talking to people, you're not enjoying the things that you love. At that point is a point to seek help, because you still have some form of insight. So I'll really, really talk to the men here. Please talk to somebody. The good thing, it's over a phone call, so there's anonymity and it's safe. Thank you.
For Bela, Risu, I would say the takeaway would be partnership and collaboration. I think more so in the social enterprise space, we tend to duplicate efforts here and there. We tend to have similar ideas, but the efforts are duplicated here and there. At Bela Risu, when you look at the program from a comprehensive point of view, there's a surgical outreach component, and then there's a comprehensive care where we give these supportive treatments for patients with cleft. We have the education and training component. We have the advocacy and awareness creation component, and then we have the capacity building component. So when you package the program, it looks quite big for one organization to handle. But for instance, when we go out into these outreaches, if we didn't have a hospital to operate in, that's where the partner comes in. If we didn't have our mobilizers to bring these patients from where they are, we wouldn't be having a successful outreach program. So if we didn't have our community advocators and awareness creators, we still wouldn't have a successful program. So when we bring these programs down to bite-sized packages, that's when we would be able to create space for everyone to step in and do their part in contributing to a larger cause. Thank you.
Okay, perfect. So remember, beautiful smiles with Bela Risu. We'll have Bena Care and then Villgro, and Clive, you can finish.
Thank you. Mine is a call to action because as I've listened to every panelist talk, I believe there is a process to which people get to a place where they are not okay mentally. And this is a systemic problem everywhere, but my main burden is in the healthcare sector, where I'm mainly addressing any policymakers in here, any institutions, the government, that we should find it in our heart to solve the systemic issues that are bedeviling the healthcare system, where a lot of healthcare workers are faced with a lot of mental illness that actually manifests in aggression and irritability that you see nurses have in the healthcare sector. And I would like to bring to attention a story that has been doing rounds this past week. There is a nurse in a place, I've forgotten, her name was Nelly, and she was a hero last week because she's the only healthcare worker in a dispensary somewhere. And she's a hero because they are saying she's operating with passion. But how is it passion when they're so understaffed that she's the only healthcare professional in a dispensary where she has to wake up in the morning and serve everybody and come the next day and the next day and the next day? So what I'm trying to say is it is very cute that every organization and hospitals and people that deal with healthcare workers will say that we are giving them extra credits for free gym, free yoga, Zumba. It's very cute. But if you cannot solve the systemic issues right from the education system, where nurses and healthcare professionals are not taught the proper skills, it's not in the curriculum on what they're actually going to face and how they can mitigate that. There's no curriculum on that. Yes, we talk about mental health, but it is not deep in the education system, right from the education system to the staffing in where the healthcare workers are going to work. If we cannot solve this chain, then it is not proper to come out and put the burden in healthcare workers to solve their mental issues, if you get what I mean. So mine is a call to action that let it be a burden in your heart to talk to policymakers and people involved to try and sort this, because if a healthcare worker is not happy, you get to have a bad user experience. And a bad user experience in hospital is potentially life-threatening. So you need that your healthcare workers are in good mental health for you to be in good mental health, if that makes sense. Thank you.
I think I'll take that home as well. Make it your burden. Just make it your burden to make someone else's mental health better, right? If you look at unemployment rates in Kenya, we have like, I don't know, 10, 15 million people out there without jobs. There are all these trigger points, right? So what can you do if you're staying with someone in your house, a sibling who is jobless, or you're staying with a spouse who has other stresses from work? Maybe your spouse is a healthcare worker. She comes home having stood for 12 hours. She's the one to do CBC homework for the kids and make a meal for you. It will not be fair, right? So do these random acts of kindness really to make the world a better place. Gun violence in the US as we are sitting here. And I was saying this year alone, up to May, almost 14,000 people have been killed. So that means this is just quarter one. So by the end of the year, you're talking 50,000, 60,000. Imagine the size of Kasarani stadium packed, people just shot. And this comes from mental health, right? So let's not wait till we flip like as a nation. And some of the solutions we build here, I am very confident they can scale and help the rest of the world. These countries, if you build something for Kenya, Kenya is like ground zero. If you build something that works for a developing country, you can scale it very easily to other nations that I need. And so as an entrepreneur, I would also be looking at, when I'm building a mental health app, which other markets should I be looking at? Thank you.
All right. Thank you so much, Doc. I think before I deliver my closing remarks, it would be a great disservice for my brother here if I don't unpack what the suicide clause is in insurance, and I believe across different companies. Now, the suicide clause only is in place to avoid moral hazard. Believe me, if we didn't have suicide clause in the insurance sector, we'd have the suicide rates increase. Now, the thing is, there is a window period of 2 years within which you are not allowed to claim insurance when the proximate direct cause of death is suicide. We have recorded cases of many people using moral hazard to be able to cash in on the sum assured. So it's there for protection purposes, for regulation purposes, and I do believe, of course, that sentiment that you've shared has been taken in good stead, because indeed we are also socially responsible to ensuring suicide rates are do deep. You did ask me who bears the risk when it comes to medical second opinion and any other insurance policy that ICA Lion offers, and who pays for it. I will do this by defining what insurance is. Insurance is a transfer of a risk from an individual who can't afford the risk. The risk could be death, disability, disease, lack of money to invest for the future, and lack of sufficient funding or planning for retirement purposes. So transfer of a risk from an individual who can't afford it to an institution that can afford to take care of the risk when the risk happens. So who bears the risk? Absolutely, 100% ICA Lion Group. Who pays for it? You do get to pay for it as our client. In closing, I want to give a clarion call to all social entrepreneurs in the house. The social enterprises you run are not physical infrastructures. They're not the desks, the laptops, the furniture, the brick and mortar, the offices that you work in. The social enterprise you run is the people that you work with. So protect your people. How do you protect your people? Give us access to your organizations. It is free of charge. It's called a financial clinic. We will come, speak to them about money in a very simple, practical way. We have tools to help them manage their personal finances better. And just to quickly highlight the research that we did, we spoke to many employer institutions and HRs. People who deal with people and culture told us this. The challenges that they face are decline in productivity, disengaged workforce, poor mental health, low creativity levels by staff members, increased need for salary advance, and the last one was negative staff attitude towards challenges. Now, guess what? All these challenges are tied to financial distress. Let's come to organizations, let's make your people financially well-being, and you'll start seeing their productivity levels go. Thank you, Dr.
Thank you, guys. I know time is also a stressor. Thank you so much for your time. We've tried to keep it and finish by 7 p.m. We want to thank all the panelists, payers, providers, those dealing with patients, entrepreneurs, investors, those putting smiles back on people's faces. We want to thank you, the audience, for your engagement and even just staying this long. Thank you.
We need to clap for Dr. Beatrice. She has run the biggest panel today. Okay, and thank you very much, our panelists. It's been a very rich session. To the audience, you are a power audience. You sat until the end. Okay, this is where we distinguish boys, girls, and from men and women. Now we will invite our panelists to start closer in front here so that we do a group photo.